Thank you for all of you coming here today, taking time. Most of you know me, and some of you don't know me. I'm an interventional cardiologist with Citrus Cardiology. I've been here for 6 years. Now this is my seventh year going on. Today the topic is to give and educate about the new, it's not a new way, but it's a different way of approaching the heart arteries, to look at the arteries of the heart, doing the heart catheterization, and as well as doing the required treatment in case you need a stent placement or atherectomy or balloon angioplasty to be done of various arteries, not only the heart, but also to the peripheral arteries and some carotid arteries also in certain conditions in a different way of anatomy required. So the topic name is the pathway to the heart starts at the wrist. That's a nice protein. How is it changing this procedure? How is this approach from the going through the radial artery from the arm is changing? This procedure has been there before, a long time ago, but we were using this procedure only when we cannot go through the groin, through the femoral artery. So it's not something new, but now it's because of the safety issues and also cost saving issues. Never been an issue in the US before. Now it's becoming an issue of cost saving, and also safety is more important. The rest of the world has been doing radial through the arm much more. In Europe, almost 90% of the caths are done through the radial approach. Canada, 50%. In India, it's 80 to 90% of heart catheterization done through the wrist, through the arm. Why US is not cut up? Because probably the operator selection. Number one, dedicated catheters were not available before. Now we have more companies are making the catheters that are different, slightly different from what we use through the femoral artery approach. In the US, this is about 2 years ago, data from 2 years ago. It's only 1% of the population in the US does from the arm. It's been there, but only 1% of the patients through this database, national registry from the Washington, showed that only 1% of the population gets the catheterization through the arm. What are the advantages and disadvantages of going through the femoral artery? It's been the longest use, history of longest use. The catheters that were designed were so easy to approach the coronary arteries without much manipulation, requiring much manipulation. So it's been used for a long while, that everybody is trained in that way, and it's been using comfortable in that way of using, and not much reason to change. Good. That's better. Right. So much easier use was the problem, is this issue there. And technically it's it's a bigger artery to feel, so it's much easier to approach and puncture the artery compared to the radial artery, which is a smaller artery, and facilitates the use of the bigger catheters in case required. The higher French lumen catheters required to use in case of the different atherectomy devices you need to do. Then it allows femoral artery allows to use a bigger lumen catheters. And the equipment design was the main reason why we've been using majority of the time through the groin or the femoral artery. The disadvantages are you have to lie down flat on your bed anywhere between 2 hours to 8 hours, especially if you had a stent placement and you cannot put a plug to close the artery there. You'll be lying down probably whole night on that bed rest. And vascular complications are higher also. It's a bigger artery, so when it leaks, it's going to leak big also. So obviously the complications are not pretty, they're more painful, and ambulation afterwards is difficult if there is a complication. More commonly associated with the back pain, and also once you put a pressure there and you cannot sit up, you cannot urinate, you have urinary retention, you have to put a Foley catheter, and a lot of other issues comes up. A lot of people cannot pass urine without sitting up or standing up. And this makes it difficult to stand up immediately after the heart catheterization, especially if you received IV fluids in the cath lab during the procedure, you receive contrast during the procedure, that all is excreted in the urine and very quickly fills up your bladder. But that cannot be passed urine when you have femoral approach with the pressure on the sandbag on, with a clamp on your groin. It's much difficult. Of course, the bleeding problem is higher because the bigger artery, and if there is an artery is diseased, mainly if they have some plaque there to start with, where you cannot put a plug to close to seal the puncture site, the bleeding is higher even compared to a normal artery. And of course, peripheral vascular disease, if they have a problem with the access there, it's going to be difficult to close also, even when you finish the procedure, at the end of the procedure. The patients who have a blockage in the arteries have higher chance of complication rates from the puncture site itself. So what are the contraindications to do? For example, you have a blocked artery there, you cannot approach, there's no pulses. Or if you have aneurysm in the aorta, where there could be clot formation inside the aneurysm, and by going through this aneurysm with the catheters and wires through them, you may dislodge some of the clots there, cause you get into trouble. Or it may be sometimes difficult to get the catheters up itself because of the aneurysms there. Unable to comply with the bed rest, somebody has a severe back pain, somebody has change in mental status, some that cannot follow after sedation, some people get very disoriented after the medication they receive in a cath lab, and they're the one that get into trouble. And also excessive bleeding risk, somebody who's on blood thinners, somebody have low platelet count, have higher risk of bleeding from this. So it's one of the relative contraindication. Morbid obesity, it's very hard to push on to stop the bleeding in obese patients. Imagine finding a femoral artery in a gentleman like this who weighs 400 pounds. Okay. Even after done, find the femoral artery, put the catheter and remove the catheter sheath. How are you going to stop the bleeding? How much pressure you have to apply to reach the artery in order to stop the bleeding? We can easily collect, the gentleman can easily collect up to a liter of blood before we can notice anything outside in the soft tissue there. If it bleeds outside, sometimes it can bleed inside into the pelvis through the back puncture of the artery into the abdomen where you cannot see at all. So those are some of the complications. So advantages, again, somebody who's on Coumadin, blood thinners, warfarin, if they're elective procedure, we can wait. Somebody can stop the Coumadin or warfarin and wait for them to lower the levels and do it. What if somebody comes in who's taking warfarin, comes with a heart attack? The hospital cannot wait. Her blood thinners, blood is very thin, INR is 2.5 or 3, very thin, very risk of bleeding is very high. What do they do with this patient? This is one of the registry that did 50 patients. I don't know if you can see the number there, it's not very clear. So none of the patients had bleeding with the radial approach. On this patient would have a high INR level, blood thinners, arm bleeding and blood thinners. Only one patient developed nosebleed. That's not related to the heart catheterization at all. Out of 50 patients who had blood thinners on board, had a heart catheterization through the wrist, no bleeding at all through the palm. So that proves the safety of the procedure, not only for people who are not on blood thinners, even people who are on blood thinners, who have low platelet count, have other problems, come into the hospital, need to get procedure done. They have higher bleeding complication if you go through the femoral artery access. Some of the studies have shown that just the radial approach alone reduces the mortality in 1 year by 17%, independently. Just by reducing the bleeding risk, that reduces the mortality in patients. So how are we not doing it? What is it different from radial artery? You needed specially little design catheters, slightly different from what they were using from the femoral artery access. Where now the companies have come up with catheters that we can use both the right and left right coronary arteries with the same catheter. We can just manipulation, new techniques, slightly learning curve to learn the technique on the approaching how to manipulate the catheters to approach. You can see the catheters here. This is the right coronary artery, and this is the left coronary artery originating. I'll show you more pictures of them. So transradial intervention means fixing the blockage. Heart catheterization means just looking at the arteries. So interventions or angioplasty, it means it's to fix the blockage. What are the advantages here? 0% local complications. Better quality of life for patients and the staff too. Imagine we used to hold the groin for 30 minutes. My fingers would cramp at the end of 30 minutes. At the end of 30 minutes, applying so much of pressure. Some of the nurses have developed arthritis in the staging from these cramps from holding groin. So people much easier. They breathe. When I tell them, hey, my patient from the radial artery coming back to you, put a little clamp there, they breathe easy. Thank God. They don't need to watch the groin. They don't need to worry about the bleeding. They just have to see the artery arm up in front of them. They can sit down at the desk and watch them. They don't even have to go there to check. So easier, much easier for the staff to monitor the patient afterwards. Reduce costs because the catheter sizes reduce amount of watching the patient. Same day discharge even after interventions. If I do morning 8 o'clock patient with a stent, it's a straightforward intervention. I'm sending them home on the same day. Yeah, you don't have to watch them overnight. So it's been relatively safe to send them home because they can walk home. All they need is the wristband and they watch the wrist. And they're there already 6 to 8 hours in the hospital till evenings, 4 o'clock, 5 o'clock, we send them home. And unless they have some other problems, so the kidney problems or other issues, or somebody is there at home, the person lives alone at home, otherwise we can send them home on the same day. All coronaries and the peripheral vascular interventions, except few where we cannot reach too far down below the knee or can be done through the arm. Vessel can easily be compressed, so the bleeding can be easily stopped. It's against the bone, right at the bone. So you have easy backup to compress. Less chance of nerve injury. Why? I'll show you the different picture of the anatomy of the nerve and artery later on. Transradial intervention. What are the limitations? What are the technical difficulties we access? Sometimes it's too small an artery to access. So it has to be like an IV line. They have to have a fine technique to finesse to get the artery. Because it's a small artery. You're not used to the small arteries. We're used to the big burning arteries there where you can easily hit. No matter how bad you are, you can definitely hit it. Okay. So it's easy to access the femoral artery, but the radial artery is a small one. You need to have some patience and access it with a little care and a little gentle touch there, because the small artery can go into spasm too. The radial artery can go into spasms. The patient is scared or anxious, they go into spasms very easily. So once you go into spasm, you cannot feel the pulse. No matter how many times you stick there, you cannot get the artery. So you need to be patient and be careful in accessing the smaller artery. And loops and tortuosity in the arteries in the elbow where the artery bends, they have some loops, some anatomical differences. 90% of the people have straightforward anatomy. 10% of the time you have little different anatomies where you have to feel free to take a picture of it before you try to push anything there. Then you can use different catheters, different wires where you can get through easily. Longer learning curve because they're not used to it. They're not trained in that way. So you're used to the femoral artery access, easy to do, easy to get the arteries, they get over with. They don't care about the aftercare. So learning curve is a little more patience initially. Up to 50 patients, up to 50 cases, it takes time for them to, little longer time to do the case, to finish the angiogram or intervention compared to the femoral artery access. Smaller sheaths, you cannot have a bigger sheath that they're used to do in the femoral arteries. Now you don't need anyway those sheaths. 95-98% of the time you don't need bigger sheaths. Most of the intervention can be done through the smaller sheaths now because the stents have evolved generations wise, and the balloons have evolved, the wires have evolved. So we're getting to smaller and smaller catheter sizes. So it should not be a problem at this point. And the guide support means when you're trying to advance a stent or something, you need some support so that catheter is not kicking out of the artery. So we need some special techniques to use that, and you need to get used to the technique how not to get these catheters backed up. And may used to use a little stiffer wires to stay there in order to counteract that. So this is the radial artery versus femoral artery complication rates. Major complications, you see that 0%. Different years, to 1996, 2003, 2000. Pool data in the femoral artery complication anywhere between 1% to 5.5% are there, whereas in the radial approach almost none. We do see some complications, not completely absent, but relatively non-fatal. They're not dangerous to life, and they're not disabling either. So much easier to manage even if you have complications. Much easier to recognize them. Much sooner we can recognize them when it happens. Patient benefit, much improved ambulation, quicker, can walk immediately, sit up, comfort, overall satisfaction is higher. Decrease instead of major entry site complication like bleeding or blood clot formation or pain afterwards. Significantly minimizing the risk of nerve damage, because the artery, vein and nerve run together in the femoral artery in the groin. We call the VAN, vein, artery, nerve. That's a sequence, it runs from medial to lateral aspect. So vein is the most inwards, artery is in the middle, the nerve runs right next to the artery. So when you blind puncture, you're puncturing it blindly, and just by the feel, you can always hit the nerve, also can cause some damage to the nerve as well. Whereas in the radial artery, it's much further away from the artery. The nerves are much further away. And low risk of bleeding complications, we mentioned that. Decreased post-procedural costs resulting from complications and follow-up visits associated with them, and mortality associated with them, morbidity associated with them. It reduces the cost as well. This again, same picture, much improved for the patient, easier to get them. How is it different for women? Which majority here, right? Women are a higher number here. So, they have smaller arteries. The body structure is smaller. They are more prone to spasms of the arteries. More significant bleeding complications from the groin side, because most of the time when they do the stent procedures, we give them blood thinners. They're weight-based blood thinners. Sometimes that's too much for the women compared to men. They have a higher bleeding risks in women when through the femoral artery. So the radial artery approach is perfect for them. So they are special, of course. Women are special, so we need to pay special attention to them, and that saves a lot of trouble and pain to the patient. This is some of the anatomy slides. I can show you the pictures. This is the artery, palmar arch. You have the brachial artery coming down from the heart and then divides into two arteries, the radial artery and the ulnar artery on the left side, on the more medial side. And they both meet, forms an arch there, or a circle. From there, it gives out to the branches to the fingers. 90-95% of the time, they have two arteries. Occasionally, about 5 to 8% of the people have only one artery there. That's the only time we should not be doing the radial approach, because if you occlude this artery, you're risking the blood supply to the hand. So we do test it before. See the arteries and veins are here together, and the nerve is in the middle, further away from where the artery we can feel. So damage to the nerve is less likely in the radial approach. And you access this artery, you have another artery to supply the arch. You have the ulnar artery supplying the arch. Even if you completely occlude the radial artery, you have the other arteries, usually smaller than the radial artery, that supplies enough to supply the blood flow to the arm, to the hand and fingers. How do we test it? We call it as Allen's test. Dr. Allen has described this test, how to check it before we do the heart catheter to the wrist. We occlude both arteries. See how pale it is now? Hand is pale. Can you see? Yes. Now release the ulnar artery, continue to occlude the renal artery, and then now its perfusion is good, better. Can you see the difference? Yeah. So that test we do before we go into the lab. In the staging itself, we check that before we go in, so that it's safe to do from the radial artery or not. If it remains pale and then release this, then it becomes full blushed, circulation is back, then it's indication that that particular patient does not have the second artery big enough to supply the circulation. That's how we check before we decide to do or not. That's only contraindication relatively to do. And this is the way to access, like an IV line, very delicate. It's not like a puncture big artery where you can, this is a very small delicate puncture, like a micro puncture kit we use to access, and pass a small wire through the needle, and through that wire we thread a small tube called the sheath into the artery. Through that sheath we pass a small wire across, and over the wire we thread the catheters. So this is how it goes from the arm, from the radial upper artery, go through the elbow, up into the aorta here, and into the arteries of the heart, approaching the heart. And this is a more magnified schematic diagram of the arteries of the heart. If you go through the femoral artery, it goes through the big aorta here, much easier to access with the catheters that are being designed for decades. They've been there. That's that. Now if you go through the arm, you're coming from here, from this artery, right arm artery, and much shorter into the aorta. And you need a little different curvature on the catheters, a little more different design to get to the arteries here. If you're coming from the left arm, you're coming from this side, go through here. This is a patient who had a bypass surgery. This is the grafts, bypass graft. This is a vein graft that they take from the leg and attach to the artery in the back. This is the vein graft. This is the mammary artery from the left arm artery that goes to the left mammary artery. They attach it to the front of the heart in the here. This becomes a difficult approach if we go through the right side, because we cannot turn around, back U-turn to get to this artery. For a patient who had a bypass surgery, we have to do it from the left arm. So we have to go to the left arm so we can approach this artery, mammary artery, through the left arm, and then go down through the aorta and approach other arteries and the bypass grafts. These are different pictures of the anatomy of the arteries. This is the arch of the aorta, this is the left arm, this is the mammary artery I'm talking about, and this is the carotid artery, left carotid artery, and the right carotid artery comes off from here. Occasionally, some patients have the left carotid artery approaching from this artery, from the right artery, right innominate artery, which becomes difficult to get to put a stent from the groin axis, from the femoral artery axis. So we go through the arm, through the right wrist, to get to that shortcut road to get a stent in the carotid artery as well. Of course, you can go down the aorta this way to the legs to fix the blockage in the leg arteries and renal arteries and so on. This is some of the loops I talked about in the radial artery. See this loop? This is the picture angiogram of the radial artery. See how this artery loops here? Makes a circle before it goes up. That makes a little difficulty. We have to use special wires to get through those first and then advance a catheter carefully. Those are one of the limitations to approach the radial artery. This is the spasms. Look at this picture on the right side, the left side too. See how small it gets? After we give sedation and some medication there, see normal again. So key to avoid the spasm is to give sedation, good sedation to the patient so they're comfortable, they're not anxious, they don't care what I do. Then it's relaxed, they're relaxed, and then there's no spasms, no further spasms there. Everything is smooth after that. This is the carotid artery we did a couple of weeks ago. See this blockage? Can you appreciate the blockage here? This patient had a surgery before to remove the plaque, carotid endarterectomy. They reblocked the scar tissue after the surgery. So get back to there is not an easy thing to do surgery again there, through going through the scar tissue. So they referred to me for stenting there. We went through the arm and stented. This is afterwards. It's a difference after the stent. And this is one of the patients who came with a heart attack. See this artery here? Almost closed, 99% blocked there. Black and thick is normal. This is where how we get thin, that's where the blockage is. And then big again. That's where the little clot sitting there. So we aspirated the clot and put a stent there. This is afterwards. After picture afterwards. So what are the cost saving? This is about 3 years ago, given by Dr. Popma in Baltimore. If everybody gets the catheterization through the arm, through the wrist, it's cost saving $1 billion to the healthcare system. $1 billion. This is about 3 years ago. Data from 3 years ago. It's a big saving, low complication, safer procedure, and easy for the patient to ambulate post-procedure. So why transradial access safer than transfemoral? Look at this, cramping up. You're almost going to crash, have a complication. Look at this, easy way. Okay. Less bleeding will allow outpatient PCI discharge patient after the interventions and elective patients. Why do you close the case? It's a little wristband that recently they came up with. One of the companies make this. A Terumo company makes this. A little inflation device there, little inflating, little bulb or a balloon underneath there. And through this sheath, there's a valve here. So we inject some air into it to inflate the balloon underneath, and that occludes the artery, compresses the artery as much as needed. You no need to 100% occlude it, just need to stop the bleeding, that's all. So if you occlude completely, it may permanently occlude sometimes, if you too long occlude also. So you just need optimal pressure there, which we can see through the artery. We reduce the pressure here and look through, it's a transparent. If it's bleeding, we can see through it, and gives few more cc's of air into it and stops the bleeding. That's all we need. And this is the patient sitting up after the procedure. No need to lie down, no need to just lay flat, no need to keep the leg down. People who have restless leg syndrome, who have arthritis, they can't cape stand, sitting up, and they walk to the bathroom. Yeah. Much easier. We call that radial lunge. Our hospital is supporting big support for this lunge and to promote the radial access because of the safety to our patients. And we have a commitment from our new administration for the Villages Hospital, and they're going to build the radial lunge here, which is going to be the first one in the Florida upstate. Yeah. Radial lunge. It'll be soon opening. We'll have the update soon, in a few weeks or months. It needs a special chairs a little higher, not recliners where the nurse has to bend down to get to the patient. They have little higher recliners, stay high. They can sit up on the patients. They don't need a bed there. They don't need a stretcher there. It takes less room there and much different to the patient convenience there. How long has been there? This is a picture taken a long time ago, 1929. Okay, this is a Dr. Werner Forsman, is a German surgeon who was fascinated with the circulation. He put a catheter on himself to experiment on himself to show the circulation exists at that time. To show different arterial and venous circulation on himself under the fluoro, under the X-ray machine, and inject the contrast. This is a catheter used for the urinary catheters. It's a Foley catheter. He injected himself through the arm, experiment to show people and take X-ray by injecting the dye, and to show the pressures that are different in two sides of the heart. Guess what? They abandoned him. They fired him from the hospital. He got fired, and he was so criticized so badly. He was so much called as wacko. So he quit cardiology, went in to become a urology surgeon. Okay, guess what happened after that? Okay, 29 years later, 3 decades later, he got a Nobel Prize. Okay, so having heart catheterization from the arm is not new. So it's been there. First catheterization was done through the arm by himself, by the doctor himself. 29 years later, 1956, I think, he got a Nobel Prize in medicine for a discovery and daring experiment, and to show the persistent that he had to do on himself to show. It's a story. It's a book there in Barnes and Noble if you want to read on him. Very interesting story how the catheterization has come up a long ways. We've come a long way, and long battle to fight against the surgical treatments versus the precardious treatments. All the shortfalls that initially came up, now we came up so many steps ahead now with the stents, drug-eluting stents, medicated stents, and so on. We came a long way from the last 50 years. That's it. Thank you. Thank you for your time for coming.